as we know that this is the most common cause of hematemesis, and the gastritis, peptic ulcers, tumors, all are the common causes for this. So we have very eminent speaker, Dr. GAURAV CHAWLA. He is from Kanpur Medical Center. He done gastroenterology from CMC Vellore, and he has more than 20 years experience in endoscopy, hepatology and gastroenterology. So I request Dr. GAURAV CHAWLA to deliver his talk.
At the outset, I would like to thank Dr. Bundelkhand, Dr. P.K. Jain, and entire organizing committee for this opportunity. So, slides are not ready. Can someone help? So, I think primary care physician also has an equal role as a tertiary care management. So, which I will be highlighting. Initial primary care management is also of utmost importance. So, what is upper GI bleed? Whenever the site of bleed is above ligament of Treace, which is a band at the second part of duodenum. If it is proximal to second part of duodenum, it is called upper GI bleed. Otherwise, it's called lower GI bleed. So, what strategy we follow when we manage upper GI bleed? Since this was mentioned by Dr. Kapil also, we have to stratify, we have to stabilize the patient, and we have to scope. So we should remember the 3 S's: stratify, stabilize, and then scope the patient. So how stable is the patient? So it's not rocket science, just we have to look at the vitals. Just see the pulse, whether it's feeble or not, how tachycardia is there or not, how a patient is having hypotension or not, or patient is in shock. So these are the parameters which can tell any bleeder patient whether he is stable or not. So ER management is important. To further objectify what I was saying, if patient is in shock, means he has lost 40% of his blood loss is there and it's a massive bleed. Even if patient is in resting hypotension, 20 to 25% blood loss is there. If it is orthostatic hypotension, then it's 10 to 20%. And if vitals are normal, pulse is less than 100, BP is stable, then it's a minor bleed. Initial management can be done anywhere, and it's less than 10% loss is there. So we have various scoring systems which can be easily done in the era of smartphones. So some score is there which we call Glasgow-Blatchford Score. So it's basically takes into account hemoglobin of the patient, which can be readily available. If it's less than 10, they are given a score of 6 straight away. It takes into account simple things like blood pressure, systolic blood pressure, heart rate, melena, syncope, whether patient is having liver disease, whether this patient is having cardiac failure, how is the BUN. So if score is 0 to 1, it can be managed on OPD basis also. Some patients may require ICU admission if they are throwing up in ER. Chances of aspiration is there, vitals are unstable, you are suspecting a variceal bleed, so some patients may need ICU management also. This was emphasized by Dr. Kapil also, that we need 2 large bore IV lines to push in the fluid. Initial fluid of choice are crystalloids. So while we are saying to push large bore lines, we always recommend 18 gauge cannulas because the flow rate matters. We can push in 100 ml per minute straight away if it is a large bore cannula compared to the smaller cannulas if we put. So flow rate matters. Your ER team should be ready with 2 large bore cannulas in any case of GI bleed. So how to suspect UGI versus low GI bleed? Sometimes it's confusing because patient may say just melena, black stools, and he's not sure. And sometimes because of the transit time, patient may have fresh bleeding PR mimicking as a lower GI bleed, but he may have upper GI bleed. But patient may have having simultaneously hematemesis. If there is an NG aspirate present, if BUN is raised, and if bowel sounds are present, all this may point towards upper GI bleed rather than lower GI bleed. So if we put RT, not for all patients, but some patients we definitely put RT. whenever we want to confirm whether it's fresh or altered blood, or we want to clean the blood for scopy, or to know whether it's a massive bleed or not, we can put RT. Otherwise, we scope the patient. Varicose versus non-varicose also, because if you have a good clinical history, you can assume what is varicose, what is non-varicose. So if you just do an examination, if patient is already having ascites, pedal edema, palpable spleen, history of alcohol intake, then suspect to be a varicose GI bleed. Or if patient gives clear-cut history, none of these factors are there, patient is having NSAIDs, smoker, previous long-standing dyspepsia, assume non-varicose bleed, and then you can manage your initial management apart from fluid and IV line medications accordingly. So, initially how we stratify GI bleed is based on the drugs, initial assessment, stabilization, resuscitation, risk. In upper GI bleed, varicose bleed and non-varicose bleed. Varicose bleed already covered by Dr. Kapil. And then non-varicose bleed, we have to start only one drug, which is PPI at doses which I will be discussing, and then take up for endoscopy. Then there can be lower GI bleed and mid GI bleed or obscure GI bleed, which are managed separately. So, what is the timing of endoscopy? So, endoscopy is nothing like you cannot, we have to stabilize the patient. What guidelines say, we should not be rushed like first thing to do endoscopy when the patient is not stable, 4 hours, 6 hours. So what they between it should be a emergency but not so urgent. So we have to 12 to 48 hours there, and it should be done after adequate resuscitation. If you do in a hurry, you may have a poor visualization, patient may be hemodynamic unstable, so you cannot do proper assessment. So he should be stable, hemodynamically stable, he should be able to bear the endoscopy, and you should do a thorough examination to find out the source of bleeding. So what time recommendation is now? 12 to 24 hours. How much blood to be given? So now we have good data, long-term Spanish study was also there. So we all follow a restrictive transfusion now policy for varicose and non-varicose, both hemoglobin level 7 with a target of 7 to 9. In cardiac patients, you can have just one more, so you can get 8 and you can go target up to 10. So just 1 or 2 transfusions usually to maintain these levels is enough. This I thought because physician and surgeon, for if you are suspecting varicose bleed, always give vasoconstrictors. Apart from basic management, we day in and day out we use our terlipressin, octreotide and somatostatin, and it should be given in correct dose, which have been mentioned here. Now for non-varicose bleed, only apart from fluids, we need only one drug, which is PPI. So initial 80 mg of pantoprazole or double dose or whatever PPI you are giving should be given stat bolus, and then infusion to be given 8 mg per hour. What it does is, it does the pH less than 7 in 20 minutes, it stabilizes the coagulation cascade, it optimizes the pH for coagulation cascade to work in an optimal way. So, if patient is on anticoagulation therapy, it should be stopped till the bleeding is controlled and then restarted later. So, what that we may have to discuss each case with cardiologist, what is the risk for embolism, how stopping may affect that condition. One more drug which we often use is the gastric kinetic. Erythromycin is usually not available, but we have metoclopramide which we use before endoscopy because it helps in better visualization. It's a gastric motility agent, so we get good visualization, and we always use metoclopramide. So prepare for upper GI endoscopy and start PPI therapy for non-varicose GI bleed. This is the initial thing which we should do. Timing which should be done between 12 to 24 hours. We should try to stratify the patient, try to stratify the risk based on initial Blatchford score, and that will initially help the patient in which way it is doing. Now, after that, we also follow 2 scores which will help in stratification. So, it's a ROCAL score, which is clinical pre-endoscopic score. So for that, if you see, we take 3 things into account: age, what any comorbidities are there, or patient is in shock or not. Based on that, score of 0, 1, 2 and 3. So if patient has more than 80 score of 2, if patient is having heart failure, renal failure, liver disease, metastatic disease, score of 3 is there. If patient is shock, again score of 2. So all these things this score takes into account, and then this score will be completed after we do endoscopy. We can find out the source of bleed, what is the cause of bleed. If this Mallory-Weiss score of 0 is there, if any other things are there, peptic ulcer disease, varicose disease, then score of 1. Or if there is malignancy, there is a clot sitting there, spurting vessel, again a score of 2. So what it correlates with mortality very well. In hospital, death is there if pre-endoscopic Roccal score is more than 4 or complete Roccal score is more than 5. So that is the thing. So other classification we always follow is a Forrest classification whenever we scope the patients. So in that, if you see here now, spurting vessel is there. So you can see a spurt of vessel which is coming here from this. So this is a spurting vessel from the base of the ulcer, and usually these are arterial bleeds in the ulcer bed. This is the ooze of blood which is happening. Then you have a visible vessel there which is happening. Then adherent clot is there which is happening. These features are very important. Why? Because if you see in this side, rebleeding rate is very high with this, up to the tune of 60 to 100% with spurting blood, and up to the tune of 20 to 30% with adherent clot. These are the lesions we need endotherapy. We may require 2 modality of endotherapy to control the bleed. And we should counsel also, if we don't do, the chance of rebleeding is very high. Even clean base ulcer has a rebleeding chance of 3 to 5%. So now once we have calculated the Roccal score as well as the Forrest classification after the initial stratification, we can counsel regarding the rebleed risk as well as the mortality risk for this patient. Now, for sometimes patient may have large amount of hemolysis, so sometimes double channel scope, water irrigation pumps and additional suction channel will be helpful in managing these patients. So there was a national upper GI bleed task force report, around 96 centers and 10,000 patient data was there. What they found that varicose bleed was there in 47%, and second was gastric ulcer and duodenal ulcer to the tune around 25%. 1% was rebleed, 3% was death. And cause of death was 52% due to non-bleed related issues. So this was a national GI bleed task. Now coming to non-variceal bleed, what are the common causes we encounter? So peptic ulcer disease is a good chunk of patients which we see in non-variceal. Other than can be just erosive gastritis, duodenitis, or sometimes GERD patient with esophagitis having GI bleed, old patient with hiatus hernia having esophagitis. Sometimes we have vascular lesions like angiodysplasias, gastric antervascular ectasias, we have Dolichois lesion, sometimes we have malignancy as the cause, sometimes we have Mallory-Weiss tear as the cause, and sometimes rare cause can be either hemophilia, hemosuccus pancreaticus, or aortic fistula. All these can be the cause. So whenever we have angioectasia, you can see here these are the malformations, arteriovenous capillary malformations happening, and this usually we can tackle with modalities which we'll be discussing here. You can see with APC we are burning the lesion there. This Dolichois lesion is nothing but an artery, submucosal artery which has come up, dilated tortuous submucosal artery which has come to the surface and caused bleeding, and then it has to be tackled, otherwise patient will bleed. GAURAV is, you can see gastric antervascular ectasia. So in the antrum of the stomach we have this malformations which can take the form of either diffuse form or watermelon form. And here two modalities of therapy which we follow usually. Either we can burn these AV malformations by argon plasma coagulation. So we give argon gas, and you can see here we are giving argon gas, and we can burn this malformation. Or you can put bands over these malformations, and then subsequently healing will happen, and then these AV malformations will get cured. So most of the data is there with APC, argon plasma coagulation in this disease of gastric antervascular ectasias, and some people do banding also for gastric antervascular. Coming to APC, APC is a non-contact thermal modality. So So usually we give inert argon gas. It is converted to ionized argon gas by a monopole electrode at the tip of the probe, and it's a non-contact. We have to just stay 2 to 3 mm away from the lesion and then give the argon gas, and usually it penetrates also 2 to 3 mm into the mucosa and coagulates. There are two modes, usually forced mode, which causes rapid tissue devitalization, or it's a pulse mode, which has a very superficial effect. Then some other modalities are diluted epinephrine, which can cause our vascular tamponade. We have to observe the blanching. We have to give, this is the vessel, we have to give at all the 4 quadrants. Usually we give diluted atoline to the tune of 1:10,000, and usually this modality has to be combined with some other modality for perfect hemostasis. And then we have contact thermal therapy also, where we can give contact, like silver probe is there, gold probe is there, we can directly put coagulation and burn the vessel here. So we have a bipolar or multipolar gold probe, in which we use 15 watt 8 seconds, or we have a speed board also, which is just uses the microwave energy, and without any cautery we can just use microwave energy and burn the thing also. Then we have other modalities of coag grasper and clutch cutter. These are also monopolar soft coagulation devices. We have to just grasp the tissue and pull, and which limits the depth of injury. Now these days hemoclips are available, where we can easily grasp the vessel and just apply hemoclip for a spurting, oozing or non-visible vessel. Various types of clips are available in market. Now they are rotatable also, and we can close and open before deploying also. Coming to a case here, 37-year-old alcoholic who is having repeated vomitings, and after 6 to 7 episodes of vomiting, he throws back again a bout of hematemesis. So there is a tear at the G junction, which we call Mallory-Weiss tear, and then hemoclipping was done and healing was started. We do a lot of ERCPs, and one person may have post-syncrotomy bleeding, which at the time of when we take out the scope there was no bleed, but after 24 to 40 hours there might be a bleeder which caused a delayed bleeding. So first principle of anything is, if you are seeing a clot at the ampulla, just wash off the clot, see what is the underlying the clot, where is the visible vessel or what is the stigmata there, and then do endotherapy. So here there was a clot where we removed the clot and then we applied coag grasper and controlled the bleeding. But we should be cautious here that because pancreatic duct is close by, we should be cautious and do diligently, otherwise we may cause pancreatitis here. Some novel tools are there. I think in the interest of time, I will just mention about them. There are hemostatic powders are available for managing non-variceal upper GI bleed. Many hemostatic powders are there. They are found to be efficacious. The widely used one is the hemospray, which has nothing but a mineral powder which is a non-thermal, non-traumatic, non-contact and non-specific targeting, and it usually absorbs water and forms a cohesive and adhesive layer over the site and leads to the stoppage of bleeding. So this is the way it is applied. Lot of indications for hemospray are there. So this can be applied at the ulcers, at malignancy patients, it can be applied at the malignancy patients also, it can be applied at syncrotomy sites also, even in portal hypertensive gastropathy patients, this modality can be used and found to be efficacious. Here it is used in post-syncrotomy bleeds. So sometimes we have a massive bleeds happening. This is an 85-year-old lady, CBD stone, ERCP already done, lab poly was done which found to have adeno-CA and lost for follow-up. Then imaging was showing malignancy and patient presented with GI bleed. So I didn't show the cause of bleed, but sometimes we have to rely on intervention radiologist and surgery to find out, to help us, because sometimes endotherapy may not work, and these are then maybe less than 2%, we may have to have IR and surgical backup to stop the bleeding. Otherwise, most of them it is. And sometimes bleed can be very terrifying also. So 54-year-old SEMS placed for metastatic malignant obstruction at T1, T2, and 2 months later patient presented with malignancy. So I'll just take a minute. video was not playing, so I'll just in the interest of time. So there was a bleeder coming out from the stent, and which could not be, clips were also applied, but it was not working. And then hemostatic powder was placed, and then later, because there was spurter, angiography was done, and coil embolization was done, and then patient was discharged. Sometimes rare endoscopic measures are there. We may have in each endoscopic unit there is a biliary fully covered SEM should be there. There should be a OTSC available for management of difficult bleeds. We may require OTSC, we may require a fully covered SEMS, and we may resort to EUS guided coiling of pseudoaneurysms. So all these are way of tackling upper GI bleed. And we can also do endosuturing, also figure of it suturing for managing difficult bleeds sometimes. So my take home message is that we should be efficient, and emergent golden hour management will influence the outcome, and that initial management can be done by anyone who has thorough knowledge of the basics of resuscitation. But expertise in endoscopy is needed for tackling GI bleeds effectively. And sometimes we may require array of accessories, which is of very paramount importance in arresting an ongoing bleed. Thank you.
That's a wonderful lecture, Dr. GAURAV. Any questions? So I request Dr. Ram Babu to felicitate our speaker. Where is Dr. Bundela?
I request to kindly felicitate our chairpersons and moderators between us, and we are really grateful to him for sharing the valuable time with us. This Bundelkhand. Dr. Vikram sir, Dr. Vikram, please.
Vikram Agarwal sir,
He is not present. So